Well, exciting news today with Dupixent getting its 7th indication with the approval of chronic spontaneous urticaria, or CSU. This is really exciting because we really have not had other biologics approved in this area since 2014. So for over a decade with omalizumab or Xolair, we've really had no new indications or therapies for this disease, this chronic spontaneous urticaria, or CSU. And when we think about urticaria, we want to always be clear on the types of patients we're treating. So this is not acute urticaria. It's patients who have had disease for at least 6 weeks. That's the separation between acute versus chronic urticaria. And remember, the vast majority of our chronic urticaria patients have CSU, about 80% of those patients. And that's important to distinguish from our chronic inducible urticaria patients, or CINDU. CINDU is associated with a very specific trigger. This can be heat, pressure, cold, ultraviolet light, for example. Very commonly pressure urticaria, so symptomatic dermatographia would be the most common CINDU that we would maybe see in clinic. And about 30% of our patients with CSU might have an inducible urticaria. But we're really talking about this group of patients with true spontaneous disease. I kind of like the old terminology, chronic idiopathic urticaria. It gets back to patients that we don't know the cause. There's no external trigger. So these are patients truly with worsening disease that's spontaneous. And about a third of these patients might also develop angioedema, which is the deeper swelling in the skin, very common around the eyes or the lips, also the acral site, so the hands and the feet. And so while we know wheals last in the skin, these superficial lesions, really about 24 hours, we know that our angioedema tissue reaction can last up to 72 hours, so an important discrimination. So we really want to look at these patients and find those with spontaneous disease. And now we have a new therapy, especially for those who may not want to be on Xolair. There's another therapy. What's really interesting about Dupixent is how it works. By blocking type 2 inflammation, we can have an effect on type 1 mediated mechanisms, which is IgE-mediated mechanisms of driving urticaria. But also with type 2 inflammation, we can help eliminate some of those patients who are having disease driven by IgE-independent mechanisms. And type 2 inflammation certainly can play a role there. So this is a great indication for patients. It's a win in dermatology because these are patients that we can easily recognize, diagnose, and now we have a familiar therapy that we know has had this robust effect on type 2 inflammation, very well tolerated, excellent safety record. And now we have really broadening of a mechanism of action that might help treat a larger proportion of these patients. As we join with allergy in taking care of these patients, we can really extend access for a disease that, if we look at the lifetime global prevalence, really 20%. So 1 in 5 patients in a lifetime may actually deal with urticaria. So this is a very common condition you may see. And looking forward to using this in the clinic, and hope you'll consider this an option for those patients who may be suffering with CSU or chronic spontaneous urticaria. Thanks.